And on behalf of CEC Oncology, I would like to welcome you to today's educational activity titled The Ever-Changing Options for the Treatment of CLL. Today's program is supported by an educational grant from AstraZeneca Pharmaceuticals and Lilly USA. So again, I'm Carrie Rogers. I'm an associate professor in the Division of Hematology at The Ohio State University in Columbus, Ohio. And joining me today, we have two other presenters. So we have Dr. Beth Feynman, who is at Cleveland Clinic, so just to the north of me here in Columbus. And she is in the Department of Hematology and Medical Oncology and also a member of the Population and Cancer Prevention Program, Case Comprehensive Cancer Center. Welcome, Dr. Feynman.
Thank you.
And also I'm joined by Dr. Matthew Davids, who is the Director of Clinical Research in the Division of Lymphoma and an Associate Professor of Medicine at Dana-Farber Cancer Institute, Harvard Medical School in Boston, Massachusetts. Welcome, Dr. Davids.
Thanks so much, Carrie. Great to be here today.
Just wanted to get started today by going over our educational objectives. So the first one is to evaluate emerging efficacy and safety clinical trial data for the treatment of CLL relative to existing data. Then we have to utilize updated guidelines and evidence supporting the use of combination regimens for the treatment of CLL. And we have to develop plans for patients with CLL across multiple lines of therapy while supporting the needs and preferences of our patients, which we all know is extremely important, especially in CLL where we have so many very good treatment options. So mostly we'll be talking about treatments and therapies using clinical data, but I just want to start by going over a few things about CLL that I think are really relevant to today's discussion. One of the focuses today is, of course, on BTK inhibitors, which is a very important class of drugs for the treatment of CLL. For anyone who doesn't know, CLL is a mature B-cell cancer and is very dependent on B-cell receptor signaling. So blockade of B-cell receptor signaling by blocking BTK prevents survival and proliferation signal and is a very effective treatment. I also just want to mention that there's some very important biomarker testing, and these are the genetic features of the CLL cells that can really help us understand what treatment options might be best for an individual patient. So these are very important to test, and you'll see us talk about some of these certain risk features and how they pertain to therapy. So one is immune globulin heavy chain gene mutational status, which is either mutated or unmutated, with unmutated being the higher risk feature. Then there's FISH panel testing to look at specific chromosome changes, with deletion 17p being the highest risk feature. Karyotype, with a lot of emerging data, including some from the recent ASH meeting, showing that complex karyotype is a higher risk feature. And then mutation testing, so that would be looking for TP53 mutations, which are high risk. And just so that everyone's aware of this, deletion 17p is actually loss of the TP53 gene, and that can also be mutated. And again, you have two copies, so you can have one deleted and one mutated, but FISH panel testing for deletion 17p and TP53 mutation testing are actually completely separate things, and you have to test for both. So I thought to kick us off, we would start with a case, just so we can think about a patient relevant to today's discussion. So this is the case of a 57-year-old man who was recently diagnosed with CLL, and he came to be diagnosed after his golf buddies noticed enlarged cervical lymph nodes. So he was golfing, and his friends were watching him do his golf swing and said, wow, you have these enlarged cervical lymph nodes. And so he got diagnosed with CLL, but is otherwise feeling very well. And so on exam, he has 2 to 3 centimeter cervical and supraclavicular lymph nodes, a spleen tip that's palpable, although not very far below the costal margin, but does actually have some concerning cytopenias. His white blood cell count was 112, with mostly lymphocytes. Hemoglobin was 10.7, and platelets were 67,000. And he had a bone marrow biopsy to evaluate this, which showed hypercellular marrow, with the majority of cells being CLL cells, and of course decreased normal hematopoiesis. He had that molecular testing that I was discussing just on the prior slide, and we found that his CLL was IGHV unmutated, which is the higher risk state. He had complex karyotype with 3 independent abnormalities, deletion 17p on FISH panel testing, and then a TP53 mutation on an NGS panel. He is overall very healthy, and his only major comorbidity is hypertension, which is well controlled on lisinopril. And so, given the state of his disease, it was felt important to proceed with treatment. And when asked about his goals, his main goals were to get the most effective treatment with the least interruption to his golf season. So he said he'll do whatever it takes to get this treated effectively, but if he has a preference, he'd prefer not to interrupt his golf much. And then he's very worried about the cost of a continuous treatment because he did some Googling and found out what drugs like ibrutinib cost per month, and is very worried that treatment will be financially ruinous for him. So those are his main concerns. So we'd like to start by just getting an opinion from everyone on what treatment options you would discuss with this patient. So the options are chemoimmunotherapy with FCR, continuous BTK inhibitor treatment, and I'm not saying which BTK inhibitor, but just broadly continuous BTK inhibitor treatment with or without the addition of obinutuzumab, the 1-year fixed duration regimen of venetoclax and obinutuzumab, or a fixed duration BTK and venetoclax combination with or without obinutuzumab. All right, so I'm very excited to see your responses. Looks like the majority of people would recommend or discuss continuous BTK inhibitor treatment with that kind of even split after that between BTK inhibitor ven or BTK or venetoclax obin fixed duration, and then a few people that would discuss FCR. So I think these are some good options or a good place to kick off the discussion. Maybe Dr. Feynman could start by commenting on what she thinks.
Yeah, absolutely. So it's interesting to me to see that chemoimmunotherapy with FCR was actually selected in this case. We have some data, which I'll show, that describes that patients with 17p deletion confer a poor prognosis when they are given FCR chemoimmunotherapy. And we have a lot of newer drugs available now that we'll go over in the next few moments that can kind of highlight what might be the right regimen. Dr. Davids, do you want to comment before I go into my portion?
Sure, thanks. I mean, I think a lot of times there's right or wrong answers to these questions. This is one question where there is one wrong answer, and that is chemoimmunotherapy with FCR. So if you said that, hopefully we'll open your eyes to why that's wrong. But I think any of the other 3 options here are actually reasonable. And I think Dr. Feynman's going to review some of the data to kind of help us understand the BTK inhibitor-based strategy, and then I'm going to talk about venetoclax plus obinutuzumab with a particular focus on this type of patient.
Yeah, absolutely. Should I kick us off then?
Yes, why don't you proceed with discussing what you think?
That sounds wonderful. So as I mentioned, and we heard from Dr. Rogers, patients with 17p deletion confer poor prognosis. And I think to backtrack, I think it's important for providers, practitioners, and I'm a nurse practitioner by background, to obtain appropriate baseline staging of the patient, as well as the mutational status, the genetic status. We have so many next generation sequencing techniques and other things that we can use to better inform our decision making. So, for example, when we first start in thinking, okay, chemoimmunotherapy versus ibrutinib, FCR was the standard of care for so many years, and there are 2 studies listed on this slide to keep in mind when you're thinking about your treatment naive patient in what to give. So in this first study of treatment naive patients by Shanafelt, that was reported in the New England Journal of Medicine, there were 529 patients that were randomized in a 2-to-1 fashion to either ibrutinib rituximab or FCR. And the ibrutinib was like daily oral, rituximab for 7 cycles, and then we had the FCR for 6 cycles. There were 175 of those patients. What we saw in that study was the progression-free survival and overall survival were actually superior in the ibrutinib arm versus the FCR arm. In the second study that's highlighted here, we see And then also the treatment naive patients, again, about 523 patients who met criteria that were age greater than 65 years in this study were randomized in a 1-to-1-to-1 fashion to the BR or the ibrutinib or ibrutinib rituximab. And again, those that were in the BR or the I arm crossover. They had a crossover at the disease progression, which I think is super important to allow those patients to have the opportunity to receive that drug in this study. What we saw in these two studies were that rituximab really didn't make a difference. You can see to the far right, ibrutinib rituximab, the curves were pretty much similar, but still superior to the bendamustine rituxan. And then to the left, which I'm going backwards, the ibrutinib was superior to the FCR. And again, I think these are really important points when we're looking at patients with deletion 17p, and ibrutinib did improve the overall survival. In this Elevate-TN study, and again, Dr. Rogers is going to go over this again later on, we're looking again at adding antibodies. Does adding antibodies help or hurt our cause? We know that rituximab doesn't really help us when we're adding it to ibrutinib. But then when you're looking at the acalabrutinib plus obinutuzumab versus acalabrutinib, it did make a difference. But when you look at the obinutuzumab and chlorambucil, again, far superior progression-free survival when you have your BTK inhibitor in this untreated arm. The next study is the Sequoia trial, and I know all these studies are like so many names in CLL, as many of our hematologic malignancies, but I think it's kind of important to get comfortable with them. And again, when I learn these drugs, you go to, the ASH conferences. We just got back from the American Society of Hematology meeting, and so that provides some great information. The ASH hematology book is really helpful, as well as referring to the NCCN guidelines. And so, and of course, you can take with you this presentation, which has some great citations in it as well. But the Sequoia trial looked at zanubrutinib, again, BTK inhibitor versus bendamustine and Rituxan, treatment naive, untreated patients without deletion 17p. And what was seen in this study is you can see the separation of the curves, the zanubrutinib in the blue, which is superior to the bendamustine and rituximab in these studies. When we're looking at adverse events, so part of our objectives are to take into consideration patient preferences. We had our case study as a golfer, and that's so important to him, but he does have some poor prognostic factors that we found on his workup, including, again, that deletion 17p status. And I can't remember, was he unmutated or mutated? I feel like he was unmutated, but he did have complex karyotype, right?
Yeah, and I was going to answer it. He did have IGHV unmutated status in the CLL.
Unmutated. So, poor prognosis, but balancing the quality of life with quantity of life is super important. And side effects and adverse effects are things that we should be aware of. When you're thinking of the class of drugs, the BTK inhibitors, so for those of you that are on this call that don't have a big familiarity with that class of drugs, I think atrial fibrillation, cardiovascular events, you want to look at which of these off-target events sometimes, like ibrutinib, for example, you can see in the Elevate-RR, which was the relapse refractory group of the same acalabrutinib and ibrutinib, there were a higher incidence of atrial fibrillation and hypertension. You can see those are bold, as well as major bleeding events. So these are types of drugs where I'd say try to avoid aspirin. Make sure, do they really need to be on Plavix? Maybe this isn't the right drug for you if you have to be on anticoagulants. But the events were a little bit higher in ibrutinib versus the acalabrutinib. And what wasn't listed here was headaches, which I see, but that's something that we can talk about later on. In terms of the Alpine studies, zanubrutinib versus ibrutinib, we don't see anything in bold because there wasn't a head-to-head comparison. However, you did, again, pretty consistently see more bleeding in the ibrutinib group versus the zanubrutinib group, as well as the hypertension as well. So lower rates of atrial fibrillation with the Acala and Zanu, and lower rates of hypertension with the Acala, but not zanubrutinib. So we're thinking of, what is best for our patient in terms of efficacy, safety, toxicity, etc. But I would go with this guy. I would go for a BTK inhibitor, probably with some obinutuzumab, right? So let's see what Dr. Davis has to say.
Oh, I was going to jump in here for a sec because I'm going to cover the addition of obinutuzumab later, so we can definitely talk about that. Thank you. That was
over that.
Yeah, I was going to say that was a really nice summary, but hopefully this has convinced everybody when you see that these BTK inhibitors compared to chemoimmunotherapy have a better progression-free survival, including compared to FCR. That it's very important that we suggest certainly BTK inhibitors over use of chemoimmunotherapy really in any patient population, and especially in this deletion 17p. And you've got this special benefit to continuous BTK inhibitors here, just because you see in the first line setting, deletion 17p CLL patients do very similarly to those without, which you don't really see with other therapies, and certainly not with chemoimmunotherapy. So based on those features you pointed out, I think I would definitely suggest a BTK inhibitor monotherapy. And while these two that you're showing here are not frontline studies, it does show that the cardiovascular risk profile of both acalabrutinib and zanubrutinib is favorable compared to ibrutinib. So for this person with hypertension, I'd probably favor something like acalabrutinib because of the lower rates of hypertension seen with that drug, which is less clear with Xanu, where you see like the AFib, but not really that much reduced hypertension. So I'm like coming in favor of that, but I really want to hear what Matt has to say about this, and also he's going to share some data on an alternative.
So I'm going to respectfully disagree with both of you, even though I think both of your answers are very reasonable to use a BTK inhibitor here. Certainly there's nothing wrong with that. But I do worry about our 57-year-old and his hypertension. He's already on an antihypertensive. And if you look at the numbers here, certainly with ibrutinib, to me, that's really concerning. Nearly a quarter of patients will have hypertension develop or worsen on ibrutinib. And when you look at the Alpine study with zanubrutinib, it really doesn't look any better. So it's about 23% in both arms of the Alpine study. So I'm worried about zanubrutinib or ibrutinib for our patient. I agree with Dr. Rogers that if I was going to use a BTK inhibitor here, I would use acalabrutinib. But about 9% of those patients will also develop hypertension. And then, of course, there's some of the other risks around bleeding. And, our patient is pretty active on the golf course, and he may slip on a rock or have a golf cart accident, and you never know. So if only we had an option that was, no cardiac risks, no bleeding risks. Oh, and by the way, it's also time limited, so he doesn't need to worry about copays year after year. And so actually, it turns out we do have such an option. And so that's what I'm going to review, which would be my preferred choice here. And that would be venetoclax plus obinutuzumab. So venetoclax is an oral BCL2 inhibitor. It was initially developed in CLL in the relapsed refractory and 17p population, actually, initially as a continuous treatment. Later was combined with CD20 antibodies to develop time-limited regimens, initially with rituximab in the relapse setting, so-called Marano regimen. But since our patient is frontline, what I wanted to focus on is the data that would sort of support using venetoclax for him, which mainly comes from this study, CLL14, which is the randomized phase 3 trial of previously untreated CLL patients who were randomized to either a year's course of venetoclax, where the initial 6 months is in combination with obinutuzumab, or to a control arm of chlorambucil, the older chemotherapy agent, with obinutuzumab. So again, a year of therapy in that arm with chlorambucil and the initial 6 months with obinutuzumab combination. And actually, our patient is a bit younger than the median age in this study, which was closer to 70 years. This was a study actually geared more toward older patients and those with significant comorbidities. You can see STEER score, which is a measure of the comorbidities of the patients, had to be greater than 6 or creatinine clearance less than 70 to get into this study. So even though our patient is a little bit younger, he does have some risk factors, especially with the hypertension. So I think he does fit with the criteria here. So this is a study now that's matured quite nicely. You can see the median observation time now is 76 months or so, and the primary endpoint here is progression-free survival. And there's a variety of key secondary endpoints around response and minimal residual disease, which will come up probably a few times during the session today. And then, of course, also overall survival. So let's start by looking at the primary endpoint of CLL14. This is investigator-assessed progression-free survival, and this is now with, I believe this is the 6-year follow-up. Yep, 6 years of follow-up here. So median progression-free survival, 76 months, a little over 6 years for your average patient on this study. You can see it at the 6-year mark, it's 53% of patients progression-free, so clearly superior to chlorambucil plus obinutuzumab. And remember, Dr. Feynman just showed you also some excellent looking progression-free survival curves with the BTK inhibitors, but you have to remember to achieve that level of PFS, with BTK inhibitors, you need that much therapy. So if you have 6-year median PFS, you need 6 years of the BTK inhibitor. So I think a key aspect of this graph, if you look at the 12, that dotted line, that's the end of treatment. So here you're getting 6 years or more of progression-free survival with just 1 year of treatment. It really speaks, I think, to the power of this combination of venetoclax plus obinutuzumab. Now, you may be wondering, what about the high-risk patients? Clearly they're not going to benefit from a time-limited therapy because they have more aggressive disease. And while it's true that these patients have a shorter PFS, as you can see here from this subgroup analysis from CLL14, I think it's actually still a pretty good PFS for the patients who have TP53 aberrant disease. As we just saw, patients with low genetic risk tend to do very well with this regimen. It's actually the second and third curves down, which are the most important. So in particular, that blue solid curve is patients treated with venetoclax plus obinutuzumab who do have TP53 mutation and or deletion 17p, so our high-risk patients. And you can see there the median progression-free survival is nearly 52 months, so a little over 4 years. And that's, again, just with 1 year of therapy. So as I think in my mind, kind of comparing across the studies, we certainly do see a little bit longer initial progression-free survival when we use the continuous BTK inhibitors in this high-risk population year after year. We have to keep using it. But when we think about sort of what would be the time until we need to switch to a different mechanism of action, I think a key question in the field right now is how effective could venetoclax with obinutuzumab be a second time? Because if you can get over 4 years just from that initial year, and you could treat again with venetoclax-based treatment and get another few years of remission, you may end up getting pretty close to the progression-free survival or mechanism benefit, I guess you could say, with the BTK inhibitors, but with a lot less therapy. Which means fewer side effects, less cost, and especially in this patient, less cardiovascular risk around the hypertension. So to kind of support that point around the AEs, they did a really interesting analysis in the recent update of the CLL14 study. We had previously seen these toxicity data. These are grade 3 or higher adverse events. We'd previously seen the column that says during treatment because they reported that during the initial publication. And as you can see, pretty high rates of grade 3 or higher neutropenia, as we expect from venetoclax. That's an on-target effect. But because we can use growth factor support and we can, dose reduce if we need to, you can look down and see the rate of febrile neutropenia was pretty low, just over 4%. Certainly, we do see some risks of infection with any regimen really for CLL, so some pneumonia. You do see some infusion-related reactions with the obinutuzumab. But I think what was really interesting about this analysis is now after treatment, with several years of follow-up, you can see very few grade 3 or higher events occurring. So that neutropenia rate drops way down to under 4%. Febrile neutropenia less than 1%. I still see some pneumonias because, again, I think that's probably more related to the CLL than any specific treatment. And of course, once you've gotten through the initial therapy, there's no infusion reactions or tumor lysis syndrome. So to me, this speaks to the good tolerability of venetoclax obinutuzumab when patients are on treatment, but also the excellent tolerability of not being on any treatment at all, which really is a nice thing for our patients. So as we kind of weigh the pros and cons of these two approaches, I'll kind of turn it back to Carrie, who I think Dr. Rogers is going to take us through sort of these pros and cons.
Yeah, thanks so much. I'll just display all of them so we can have a discussion. And I do, before we launch into this, I want to address one question that was asked, which is when we were talking about biomarkers, the question is, should they receive something broader than just IGHV and deletion 17p or TP53 testing? And I think the key ones for treatment decisions are going to be the IGHV mutational status, 17p, but usually that comes with a FISH panel where you can see if they're going to be in a very good risk category like the deletion 13 patients or high risk, which again helps you counsel your patient, but not necessarily identify like who wouldn't really benefit from chemoimmunotherapy. I want to point out that it's really important to order the TP53 mutation testing separately because you don't get that with the FISH panel, even though sometimes the FISH reports say something about TP53, it's not the same. In terms of like broad panels, you can get them that'll show things like Notch1 and other like mutations that could be in the CLL that do have some prognostic value. We have a panel at my institution that gets all those, but I think the highest impact beyond just the IGHV and FISH panel is going to be making sure the TP53 mutational status is done, especially when thinking about therapy. I also like ordering karyotype, which isn't like a foundation send out, it's cytogenetics, just because it helps me understand things a bit better with complex karyotype as an emerging feature. And I don't know if Dr. Feynman or Dr. Davis has anything else to add to that. Otherwise, we can move on with our discussion.
No, I think the only point that I would like to make is that each institution is different and you have different panels. And so if you're not familiar, if you don't see a lot of CLL patients, maybe find out who the pathologist is, who you work with, or if it's a send out test, and maybe they can provide some guidance, because I've seen where some providers are ordering tests and don't even realize it's not the right test, and that can be kind of confusing sometimes. I don't know if Dr. Davis has any other thoughts or suggestions for our community providers on the line.
Yeah, the only other thing I would add is really just to underscore the importance of IGHV mutational testing. Sometimes I hear from community colleagues, it doesn't matter so much because I'm going to use a targeted therapy anyway. I'm not making that decision anymore between chemoimmunotherapy and targeted therapies. And certainly in that scenario, IGHV status is really essential. But I'd still argue that it's important. It really is fundamental to the biology of the disease. CLL is almost really like two different diseases based on IGHV mutated or unmutated. I think you'll see that as a theme as we go through some of the rest of the data, but even with some of our very powerful time-limited regimens now, we're seeing very different durations of response and MRD rates based on IGHV mutational status. So I think it's helpful even because you can check it right at the diagnosis. It doesn't change throughout the lifetime of a patient with CLL. So I like to get it right off the bat. Helps with counseling around the likely time to first treatment. Patients can kind of maybe plan their lives a little bit around that. But then again, when you're starting treatment, there is relevance to the progression-free survival and MRD rates and things like that. So I find that helpful to have.
I'll agree with you there and fully support that instead of disagreeing, especially because some of these fixed duration regimens we're talking about, like the venetoclax obinutuzumab or the BTK inhibitor venetoclax, which is not approved in the United States, but I think we're going to have a little bit on that later. And I don't remember if we really broke out the IGHV mutated, but the progression-free survival is extremely good with that. And so that is a very good reason to do a fixed duration therapy, because you really limit side effects and costs in that patient population with an outstanding result. And so it's really important to get that. And I advocate for fixed duration regimens in that patient population. Here, I think Matt made some very good points about what a fixed duration regimen might do for, like returning to this discussion, might do for our patient who's a golfer and has hypertension, especially when you look at that median progression-free survival of like over 50 months. That's not bad. So that's better than chemoimmunotherapy. That's a very nice benefit. And that's also like probably the chance that that person will have to be off treatment for some time, especially when you get into later lines of therapy. People tend to need, kind of continuous treatment. What I usually think, so I think that's also a great option for a discussion with the patient. I usually like to try to maximize my benefit from first-line therapy, so suggest continuous BTK inhibitors, just because you're having fewer relapses, which is always like challenging for patients to go through, CLL disease progression. But I certainly would see the benefit of the other and would have no problem offering that. I don't know if anyone else wants to jump in on some of the discussion points we have here. I think we covered a lot of them.
Yeah, I think, the only hesitation I have for our patient is that it is a bit inconvenient to start venetoclax plus obinutuzumab. First, you have the infusions, which are not trivial, both in terms of some of the early toxicities like infusion-related reactions, and then also just the time that you need to come in to spend. And then you have the venetoclax ramp up, which is the 5-week ramp up with, a couple days in a row, at least for the first 2 weeks, and then weekly monitoring. And, our patient does want to be out there on the golf course. So I hear him. But this is a patient where I might really try to convince them, look, you got to kind of pay your dues for the first couple months, but after that, it's smooth sailing, and that way you can get off therapy at the end of the year. So that's kind of how that conversation would go.
I wonder if you could do that during not golf season, if you'd be more open to it.
Yeah, that's a good idea. We don't usually need to treat right away with CLL, so maybe if it's like the fall, you could drag your feet a little bit and get those 2 months done during the winter. I like that idea. Unless
you live in Florida. The only thing that I would say is that this is a perfect discussion for shared decision making, right? So I think it's, Dr. Rogers said at the very beginning, there's so many effective regimens out there, and there are many different options. And so that's where you say, what are your goals? And maybe short term, we want to do a fixed duration therapy, save your bank book if you don't have any copay assistance available for the BTK inhibitor. And then the long-term trade-off is that after this fixed duration therapy with the Venobi, then maybe we can just, take a treatment-free interval, and watchful waiting is what we would do. So that would be the kind of twist I would put in for that.
Yeah, I completely agree that this is an excellent opportunity for shared decision making, and I'll get consults that people come see me here for an opinion on their care for CLL, kind of in that window where they're like, oh, I probably need treatment soon. I need to pick something, but I don't have to start right away. And so I usually start by asking people what brings them to my clinic and what I can do for them. And some of the responses I was getting was, tell me what treatment I should do. And I was like, I can't do that. We just met. I don't know you. And until I get to know you, your health history, and also what's important to you, I can't tell you what you should do. Like, I need to learn some information about you, because understanding from the records you get, if the risk stratification, like those biomarkers were done, understanding like the biologic features of the CLL are certainly one component of that, but patient health conditions and patient preferences are also another component of that. So I think it's just interesting. People think I can tell them like, oh, what treatment should I do? I'm like, I don't know. I don't know you yet. I'm sure by the end of our time together for this consult, we'll come up with together what the best option is.
Yep, totally agree. I have a very similar approach with my patients.
Yeah. And I think just to advance the discussion a little bit, we could cover a few things that could be different about patients that might lead us to have a different sort of selection for them. And I think we already sort of covered the IGHV mutational status one. I don't know. Did either of you have anything else to say about that group compared to what I said?
No, I agree. I would emphasize for mutated IGHV patients, that's really where I think you're getting the best bang for the buck, so to speak, with Ven/Oben. I actually didn't show it in my part, but the median progression-free survival is not even close to being reached at 6 years. So I mean, we can extrapolate out. It's probably going to be 8-9 years. I don't know. And that's pretty impressive for a 1-year treatment.
Yeah, and what's exciting is we're starting to see, and again, this is not approved in the US, but the Captivate, which is ibrutinib venetoclax fixed duration, it's like 15 cycles of 28 days, so a little more than a year. Looks like we're getting the same in our mutated patients. So again, like not sure one or the other of those are better in that population yet, but it really supports that a fixed duration therapy is best. I think we did sort of cover cardiovascular comorbidities too, and how that's a concern with the BTK inhibitors, but we didn't discuss renal insufficiency and how that might impact choice, or sort of what the things are that might make you think that venetoclax is a less suitable option. I mean, our golfer didn't have any of these, so I don't know if maybe Beth or Matt wants to jump in with some of the things that make them worry about giving the venetoclax-Oben approach.
Yeah, I mean, I can start. I think, with the renal issues, that's definitely a concern, especially around tumor lysis risk, not just with the venetoclax, but also with the obinutuzumab, we can see some TLS. So the good thing is in that CLL14 study that I showed you, they were pretty liberal because it was a study of older patients with comorbidities. The eligibility there was a creatinine clearance of greater than 30. So that definitely covers a lot of our patients, even older patients. I do get more hesitant to use Ven/Oben in patients with a creatinine clearance less than 30. If they were a candidate for a BTK inhibitor, I probably would use it for that reason. If they weren't a good candidate for a BTK inhibitor, I'd still consider using Ven/Oben, but I might even be cautious about the starting dose, like maybe 10 milligrams of venetoclax, maybe have them in the hospital for very careful monitoring. So that's kind of how I handle that. I mean, hepatic insufficiencies really applies across all the drugs we use because they're all processed in the liver. So, if you have a patient with severe hepatic insufficiency that's not being caused by CLL, that's problematic for all these drugs, but not, to my knowledge, necessarily one more than another.
I worried too with venetoclax, not just renal insufficiency. I agree with you on all those points, but also patients that can't handle hydration, because especially if it's a high. So the scheme for how you reduce the risk of tumor lysis syndrome depends on disease burden. So for people at a higher risk that need more hydration, sometimes that can be really hard, especially for people that need diuretics. Again, the cardiovascular risk is safer, but if you have heart failure requiring a lot of diuretics, that can be really challenging. So I think about that a little bit and how to mitigate that. If I have someone that could use venetoclax or maybe a BTK inhibitor, would be simpler in that population. I also want to briefly just touch on the like younger fit or older frail. And I think, CLL is mostly an older patient population, although not exclusively. But I think the like fit versus unfit is kind of interesting because in the chemoimmunotherapy era, that was a huge divider between like who could get FCR, who would get obinutuzumab and chlorambucil. And I really feel that's not the case so much anymore. I think that all these targeted agents are potentially suitable even for older, markedly less fit patients. So I've prescribed acalabrutinib to people in their 90s before, and it went great. And I think there's some really interesting data that's pretty recent on this across the BTK inhibitor studies, which I know Dr. Feynman covered, the FCR versus IR and the BR versus I versus IR. We didn't show this, but if you look at side effects in the studies, the FCR was a younger population than the study that had BR, and you really see the toxicity is more in studies between like older and younger patients with like a venetoclax, ibrutinib. You see more discontinuations in older patients. So I think that fitness, while certainly not exclusionary for BTK inhibitors, does seem to matter as it does with most therapies. And I was really struck by a recent presentation of data from CLL14, which Dr. Davids covered, and a study called CLL13, which was the same regimen as in one arm for fitter patients, and the PFS curves there, or progression-free survival, is completely overlapping, at least at the current follow-up from those studies. Granted, with older patients, you're eventually going to see a difference because people will die of other things, right? But I was just struck that it doesn't seem to matter about age or fitness with the venetoclax obinutuzumab combination, and I'd love to hear what others think about that.
I agree. I think that where we were 10 years ago versus now is so different in terms of thinking about it. These therapies, we are better understanding how to use them, what combinations, and what's always impressive to me is to see the long follow-up. So, and you can see like in clinical trials, progression-free survival is a major primary endpoint because the overall survival is so long and it takes so many years to achieve that endpoint. But we're seeing 5-6+ year follow-up on these studies, so we have robust information of the safety and the efficacy. And I can't wait to see what the maturity of the future studies with MRD status, et cetera, is going to bring for us.
Yeah, I agree. I think as I think about those scales of justice between the two approaches, young fit, in my mind, does often kind of fit better for the time-limited approach. I worry about our patients in their 50s, say, who maybe have to commit to a decade or longer of being on a BTK inhibitor. Whereas if I have a patient already in their 80s, say, if I can get them a decade on a BTK inhibitor, that might be the only therapy they ever need for CLL. So certainly we can go either way, but those are some of the things I'm thinking about with the younger fit patients, especially, is the idea for the time-limited therapies being preferable.
Yeah, that's a really good point, thinking about someone's natural lifespan. I always get people in their like 50s and 60s with BTK inhibitors say like, do I have to take this for the rest of my life? I'm like, well, I don't know, how long are you going to live? Because if it's 6 months, like, yeah. But if it's longer, like, no, I'm sure we'll figure something out in a decade. But it is still like years of taking drug therapy. For everyone I've given a BTK inhibitor to in their like late 80s or 90s, I haven't had anyone ask if they have to take it for the rest of their life. They're usually like, cool, fine, sounds good. This seems like it'll work. And yeah.
Yep.
So, well, I think to move forward, we are going to let Dr. Feynman present the update on what happened with our patient.
Absolutely. And I just want to say this is such a great discussion with some practical tips, and hopefully you'll find the rest of this discussion interesting. So what happened to our patient? So this is the continuation. He's on the covalent BTK inhibitor. He did receive acalabrutinib and obinutuzumab. Remember, he had all those, the complex karyotype. He did want to golf, but the mutual discussions, that's what he felt most comfortable with. So during treatment, he experienced GI bleeding events that were minor, but still very disturbing, but they did clear without any treatment. His hypertension remained under control, and he remained in a CR with detectable MRD. However, 39 months, he experienced disease progression. So he had some supraclavicular lymph nodes that were enlarged. His white count was up to 80. his hemoglobin was dropping, as well as his platelets, which was similar to his disease presentation. A repeat bone marrow biopsy, which is an interesting point that we might want to discuss, restaging and how each of us do it in our practice, but his bone marrow biopsy showed hypercellular and 55% involvement of CLL. Repeat next generation sequencing and karyotyping, again, looking at the disease characteristics, did confirm that he still had the same complex karyotype, which usually doesn't change. You usually don't change your del17p status either. Again, signaling, however, that he had this positive TP53 mutation. His current revised treatment goals are to continue to receive the most effective treatment that he thinks is best for him with the provider team, discussing the risk benefits, etc. His daughter recently married, and now he's expecting a child, and he's still golfing. So we need to maintain his quality of life. So with that, we have another poll. So which treatment options would you discuss with this patient? Switching to zanubrutinib, venetoclax and obinutuzumab, venetoclax and rituximab, or off-label pirtobrutinib, which is a hot topic these days. Oh, interesting. So I think somebody made a point for venetoclax obinutuzumab. With Dr. David said shared some great data, venetoclax rituximab, switching to zanubrutinib, and then off-label pirto. I've tried to skew the responses by saying this is a hot topic of conversation. So this is not yet approved. You need to have fail a BCL2 inhibitor and a BTK inhibitor. So he actually wouldn't be a candidate for that particular treatment. Dr. Rogers, what do you think about this?
Yeah, I think this is great. So with the off-label pirtobrutinib, while that's not one of the current indications, there is certainly data to support that we're going to show some later. That's a non-covalent BTK inhibitor. And in terms of switching to zanubrutinib, we didn't show this data for our patient, but the majority of patients who progress on a covalent BTK inhibitor have mutations that would confer resistance to the whole class. And also just biologically, the drugs bind BTK at the same site in the protein. So it's very unlikely that one would get much of a response to an alternate covalent BTK inhibitor. So for disease control, this would really require switch to a non-covalent. I definitely love that people are showing that venetoclax is a highly effective therapy here. I think it's interesting. A lot of people want obinutuzumab because that is off-label. So in the previously treated setting, rituximab is the approved anti-CD20. However, I was talking about that CLL13 trial, and there's certainly data in the frontline setting to support that obinutuzumab is markedly more effective. And so I think I would actually go with the most popular choice here for this individual. But I'd love to hear what other people think.
Yeah, I mean, one comment on this case, I think we're going to get to this much later in the presentation, but it's an unusual choice to add the obinutuzumab to the acalabrutinib in a patient with TP53 aberrant CLL. So I think Dr. Rogers is going to show you some data later suggesting that may not be necessary, that you might just want to use acalabrutinib monotherapy in that scenario. So hold that thought for a little bit. We'll get back to that point. I think with regard to this point, certainly agree with Dr. Rogers. I would not switch to a different covalent BTK inhibitor. So I think the choice here is around a venetoclax-based regimen or pirtobrutinib. Although pirtobrutinib would be off-label, I think there are good data to support that, and I'll show you some of those data in a little bit. And I agree within the two venetoclax-based regimens, even though there's not a lot of data to support ven-obin in the relapse setting, I think I feel comfortable extrapolating from the frontline data that Dr. Rogers mentioned that ven-obin is a more powerful regimen. So that would also be a great option here.
Sounds good. Dr. Rogers, do you want to share some more data to support your point?
Yeah. So I'm going to talk a little bit about actually venetoclax use here. So I think it's important to note that patients with continuous BTK inhibitor therapy develop resistance. So a fraction of them will discontinue for intolerance or in a setting where they're not resistant, like the CLL cells aren't resistant. And again, the list there is 16 to 23%, but it's going to go up the longer people are on treatment. So the longer people stay on the drug, the more frequently we see resistance. Most of the information we have on reasons for molecular resistance on a biology level come from studies with ibrutinib, just because the BTK inhibitor has been around longer. And while we are potentially seeing some slight differences between ibrutinib, acalabrutinib, and zanubrutinib, they have extremely similar mechanisms of action and the same binding site on BTK, which is at the C481 residue. And so it's unlikely that anyone would get a durable response to a different covalent BTK inhibitor. And we think these are similar. It was exciting to see, again, at the recent ASH meeting, some updates on slight differences between the drugs. But again, these are going to not result in durable benefit for switching because the mutations we see in the resistance mechanisms are similar. The most common mutation we see are mutations at the C481 residue, most commonly C481S, and that's at the binding site. So it prevents attachment of covalent BTK inhibitors. Some of them still have some reversible binding, but again, not highly effective. Resistance is more frequent in patients who have experienced multiple prior treatments, as you'd expect. The more treatments you get, the worse the disease biology. And then patients with TP53 abnormalities, and that's in the previously treated setting. In the frontline setting, the PFS is similar. But I think this is an ongoing area of investigation that we hope to learn more about. And I know Dr. David's going to cover some things with the non-covalent BTK inhibitors that are relevant to this information. So what I'm showing you here is the Murano trial. So this is the phase 3 study that led to the approval of venetoclax plus rituximab. And so it was a randomized phase 3 comparing to, again, chemoimmunotherapy, which was the standard at the time. And it was chemoimmunotherapy with bendamustine and rituximab. You can see on the slide kind of the diagram there. So certainly the exposure of venetoclax was longer. So it's like a 2-year exposure. And also, unlike CLL14 with obinutuzumab, you actually ramp the venetoclax up and then start the 6 months of rituximab. So it's a little bit different. And again, like a longer duration of venetoclax at 2 years instead of 1. What's really important here is just that the prior, it's B-cell receptor signaling inhibitor, so that's both BTK inhibitors and PI3 kinase inhibitors, that exposure was low. So you're looking at 1.5% or 2.6%. So this study is absolutely not in the population of patients who have CLL that's become resistant to a BTK inhibitor. So while this is a highly effective regimen, the results that we see with this can't really be translated into a previous BTK inhibitor treated population. So I'm showing you here progression-free survival. You can see markedly better with venetoclax and rituximab compared to bendamustine rituximab. So I don't think I have to point out how far apart those curves are. You're looking at like 53.6 months versus 17 months. So clearly the Murano regimen is better. And again, you see the little arrow on there for end of treatment. It's really nice that patients are experiencing time off treatment where they're in remission, which is a major benefit of the strategy, even in the previously treated CLL setting, where, usually in prior lines of treatment, you don't get the same benefit as initial treatment. And again, the drug treatment's 2 years instead of 1, but still this is a nice benefit. And I think we already covered some of the side effects here that are seen with these venetoclax regimens. So thinking about that for your patient. And then there's an overall survival benefit, which again is not surprising. You do see that there remains a difference in patients with or without TP53 disruption. Again, that's deletion 17p where it's deleted or mutation. And so the arms we want to look at here are the 2 blue ones. So the red arms are the bendamustine rituximab arms. So we want to look at the blue, which are the venetoclax rituximab, and you can see patients with no deletion 17p as that top line. So you do have kind of worse outcomes with deletion 17p or TP53 mutated CLL, but again, both those are markedly better than bendamustine rituximab. So these are very good results for this regimen, mostly applying to patients treated with chemoimmunotherapy previously. So the disappointing thing is that we don't see these same results with venetoclax in patients who were previously treated with a BTK inhibitor. So I'm showing you those same curves for Murano in the blue and the red, and then what's layered onto this is that black line in the middle that's kind of close to the BR line. still like better than that. And that's actually from a completely different study. So that black line you're seeing on there that says 2L then is actually from a phase 2 study that was specifically in patients who had received ibrutinib. It was actually a study that had either ibrutinib or idelalisib, but this is the ibrutinib data. So you're really looking at, a median progression-free survival of 2 years, which is right around the time venetoclax ends in Murano. Now, granted, that study did not have the rituximab added to it, so it is a little bit different. And also, it was a continuous venetoclax, so it wasn't planned to stop at 2 years. So I think this is expected that later lines of therapy, again, wouldn't do quite as well, but also showing you that even in previously treated patients, if patients have received ibrutinib, again, this is in the era of ibrutinib, I would expect similar with zanubrutinib or acalabrutinib, you're getting less benefit. So there's a markedly less benefit to venetoclax here. I know that there's some real world evidence being generated now, just looking at, okay, if you add obinutuzumab here, can you do fixation? If patients weren't as heavily previously exposed to chemoimmunotherapy before they took ibrutinib, would this be a little bit better? So I think that remains an ongoing question, but I just want to point out that after BTK inhibitors, the benefit to this approach is less. So you can't counsel patients who have had CLL progression on a BTK inhibitor about the Murano results. Okay, and then here we just have a multi-center retrospective study of patients with CLL who received venetoclax after B-cell receptor signaling antagonists, which was mostly, again, BTK inhibitors. Where you can see that, again, patients who received those, that's the dashed line, which is the yes, don't have the same outcomes as patients who didn't. So I think that it's just important to realize that when you're counseling someone on venetoclax use after a BTK inhibitor, you have to make sure you're looking at data specifically in that population. Still more effective than any other therapy that was approved until we had pirtobrutinib recently. And on that note, I was going to turn it over to Dr. Davids to cover some of that information.
Great. Thanks, Dr. Rogers. So do we really need a fourth BTK inhibitor in CLL? Well, actually, it turns out, yes, we do, because there's really a fundamental difference between the covalent BTK inhibitors and the non-covalent BTK inhibitors. And I'll try to illustrate that on this slide here. So on the left, you can see the three drugs you're probably most familiar with. These have all been approved now for a while. Ibrutinib for a decade or so, acalabrutinib for about 4 years since its approval in CLL, and zanubrutinib, which was just approved for CLL earlier this year in January, but we've been using for a while in other diseases like mantle cell lymphoma. So we're also familiar with this mechanism of the covalent BTKI. They basically require binding to the cysteine 481 residue, as you can see illustrated here. And once they do that, they bind irreversibly and they can continue to inhibit BTK very effectively. The problem is that a common resistance mutation that's arisen in all three of these drugs is a cysteine to serine mutation at site 481. There's a variety of other mutations that can occur from that cysteine at the same site. And as you see here, when the cysteine is there, you can bind. When it's there, when it's not there, you really can't bind in a covalent way. Some of the drugs like ibrutinib can still get in there and have a little bit of transient reversible inhibition of BTK. But for example, acalabrutinib really has almost no effect at all. So really this mutation at the cysteine 481 renders the BTK active again, and these drugs no longer work. And so that goes back to Dr. Rogers' point before. If you have a patient progressing on one covalent BTK inhibitor, this is very likely the mechanism of resistance, and therefore it's very unlikely they would benefit from a different covalent BTK inhibitor. So that's why it is so important and really exciting to see the development of the non-covalent BTK inhibitors on the right. So there's two of them now. There's pirtobrutinib, which is just recently, this past couple of weeks, FDA approved for CLL. And then there's nemtabrutinib, which is still in development for CLL, but now in late phase trials. And I'll review the data on both of these in a second, but just to kind of give you a sense for how these are different. So you can see the way that these drugs bind to BTK is fundamentally different from the way the covalent inhibitors bind. And obviously this is a bit of a simplification here, but if you kind of imagine it targeting other parts of BTK and not really caring whether there's a cysteine in that 481 site, you can see on the left side of that non-covalent part or the right side, whether that's a serine or a cysteine, it doesn't matter. The drug can still effectively bind. It's binding in a reversible non-covalent way, and it can very effectively inhibit both the wild type and mutant BTK with several different types of mutations, although there are some mutations where these non-covalent inhibitors also may not work. But certainly in the common mutations that we're seeing arising on the covalent BTK inhibitors, for most of those mutations, the non-covalent BTK inhibitors can be effective. So as we think about these two drugs, they are very different in terms of their kinome scans here. So you can see on the left, pirtobrutinib is highly specific for BTK. In fact, of all the BTK inhibitors we've discussed so far, it is the most selective. You can see there's very few other red circles besides BTK, suggesting there's few off-target effects of pirtobrutinib. On the right, you can see nemtabrutinib also very effectively targets BTK, but does have a number of other off-target effects you see illustrated there. So we think this may have some implications around the toxicity profile of these drugs, although I would say in practice, both of these drugs are generally pretty well tolerated for most patients. So let's start with the agent that's not yet approved, that's nemtabrutinib. So most of the data we have on this drug in CLL comes from the phase 1/2 BELLWAVE study. This, as you can see, included patients with CLL and SLL with a variety of different characteristics. Many of these patients had prior covalent BTK inhibitors and the BCL2 inhibitor venetoclax. Many of them, as you see, had C481 BTK mutations and also high genetic risk features like deletion 17p and unmutated IGHV. There was an initial phase 1 portion where there were some lower doses explored, but what I'm showing you here is the patients treated at 65 milligrams, which was the phase 2 dose that's being taken forward. And you can see across those different subgroups, whether based on different therapy types or different genetics, there was a pretty high overall response rate in the range of 50 to 60%, depending on the subgroup. These are mostly partial responses, as we expect to see with BTK inhibitors. And you can see the median progression-free survival ranges from about 10 months in the high genetic risk patients up to over 2 years, 26.3 months in patients who have C481S mutations. And so if we kind of look in a little more detail at the curves for progression-free survival on nemtabrutinib, you can see this now broken out by a few of the different cohorts. So the cohort with the best progression-free survival is kind of that overall cohort, 26.3 months. And those are patients without a C481S mutation. Then it's a little bit shorter, cohort A, 15.7 months in patients who have a C481S mutation. And so, this is certainly promising data. It was enough to lead to the development of a phase 3 study, BELLWAVE 008, which is now in accrual. And, I think one of the exciting things is it's looking at patients with previously untreated CLL without TP53 aberrations. So they're very aggressively going, initially into relapse refractory, but then all the way up through frontline studies to explore the utility of nemtabrutinib in those contexts. We have much more mature data, though, now for pirtobrutinib, the agent that was just recently approved here. And so these come from the BRUIN phase 1/2 study, very large phase 1 study with, at this data analysis here, 618 patients across relapsed B-cell malignancies. And if you start to look at the subgroup of patients with CLL, there's about 296 in total. Some of them had not previously had a covalent BTK inhibitor. So for the purposes of this presentation and our patient, I think it's most useful to think about the patients who had previous exposure to a covalent BTK inhibitor. And so that's the 252 patients included in the efficacy population. And in this early phase study, you can see the usual endpoints, primary endpoint of MTD and recommended phase 2 dose and variety of efficacy and safety secondary endpoints. So, as I showed you with that kinome plot, the theory was that pirtobrutinib would be well tolerated since it's so BTK specific. And now from the BRUIN study, you can see in practice that does appear to be the case. So very low rates of grade 3 or higher toxicities, really just the neutropenia in about 15% of patients. Otherwise, you do see some low-grade toxicities as you'd expect with a BTK inhibitor, like bleeding. Bleeding is a very loosely defined term in most of these studies, includes things like, petechiae or minor epistaxis, things like that. So, although the rate of bleeding was relatively high, these were not typically serious bleeds. Also, very impressively, a very low rate of atrial fibrillation flutter, 1.3%, also hypertension, 3.8%. This is certainly lower than what we've seen with the covalent BTK inhibitors, but you should remember this is still pretty early data with pirtobrutinib in terms of length of follow-up and numbers of patients treated. So certainly promising so far, but we'll watch for updated safety data as it emerges. Right away, though, we can see the efficacy of pirtobrutinib is really outstanding for this population. You can see in patients with previously treated CLL with previous BTK inhibitor exposure, the overall response rate was 82%. And in patients with double exposure to both BTK and venetoclax, it's about the same, 79%. Again, mostly partial responses. You can see in the waterfall plot in the top right, that's the lymph node decrease in individual patients. And you can see a really impressive waterfall plot with nearly all the patients having at least a 50% reduction in their lymph node disease. And importantly, if you look at the patients who had previously progressed on a covalent BTK inhibitor, that's the dark blue bars, compared to the patients who had come off a BTK inhibitor previously due to toxicity, that's the light blue bars, you can see there were patients with both characteristics that all enjoyed a deep response. There was no difference in terms of depth of response based on the reason for prior BTK discontinuation. And then you can see the asterisks at the bottom of the waterfall plot in the top right indicate patients who also previously had venetoclax. And again, really no difference in those double refractory patients in terms of the depth of response. So if you look at the overall population from this study, you can see that the median progression-free survival is 19.6 months. And remember, this is a very heavily pretreated population, most of whom had prior double exposure, many of whom had also progressed on a prior BTK inhibitor. And so if you then kind of break down some of these subgroups here, you can see that the BCL2 naive patients, in other words, really just exposed to covalent BTKI plus other therapies, did have a little bit of a longer progression-free survival, median of 22 months, but still, even in those double refractory patients, close to 17 months median PFS. And on the right, importantly, whether patients had mutant BTK at the C481 or not, those patients had similar median progression-free survival. So this is clearly a very effective therapy. We saw data just before this showing that venetoclax is also a very effective therapy. We do not have any prospective trials right now comparing these two approaches, but we are sitting across from patients who need our guidance to help make these decisions. So one option is to just kind of do what we just did, kind of compare across the studies, like eyeballing them and seeing how they line up. But there's a systematic way to do this called a matched adjusted indirect comparison, which is imperfect, but it is one way to try to kind of figure out what are the differences in the baseline patient characteristics between the two groups, kind of match those up and try to make the comparison a little bit more fair between the two approaches. And so we're involved with this MIAC, as they're called, comparing pirtobrutinib to venetoclax in a post-BTK inhibitor population. So this study pulled in data from the Bruin study, which I just showed you, and from a venetoclax study that Dr. Rogers had shown you in the post-BTK setting, and adjusted for patient characteristics as much as possible, and then tried to line up the curves. And so on the left, you can see the progression-free survival. On the right, you can see the overall survival. And to my eye, they look pretty similar. So you can see pretty similar PFS, whether you use pirto or venetoclax in a post-covalent BTKI population. And I think that's nice. I mean, again, it's not definitive data. It's not a randomized study, but it suggests that as we're talking to patients and goes back to sort of our shared decision-making, I think we could be supported in using either approach. And there may be certain patients who prefer one over the other. And I think it's nice to have some data to support that. So I think with that, I'm going to turn it back to Dr. Feynman to kind of review our patient and some of the possible scenarios here.
Thank you so much. And I just think that this is such a great discussion, and it's almost an embarrassment of riches, right? So if I'm hearing from you too, like if your patient has maybe some, covalent BTK resistance, think about a non-covalent BTK or venetoclax base, that would be fine. Again, we don't have any head-to-head trial, phase 3 randomized trial data are the most robust, and we don't have that currently, but we do have other trials that inform our decision making. Dr. Rogers, I'd like to turn over to you, maybe comment on what your thoughts are in a patient that might have like renal disease. I mean, we kind of covered this before, if they had renal disease, maybe that's where you'd go to the BTK versus venetoclax, second line or even third line. What are your thoughts about the data that were shared?
Yeah, I think that people chose BTK inhibitors for a reason the first time. And so some of those reasons persist, right? So if they, for their first time chose a covalent BTK inhibitor because they weren't able to come for the ramp up. I work in Columbus, Ohio. People travel 2 hours to get here, and sometimes it's not practical for them to come for a ramp up, or is a very high burden for them. Also, people have renal disease. So some of those reasons that people didn't want venetoclax up front still exist for them when they're picking a second therapy. So I think that is really a reason to consider off-label use of pirtobrutinib. I mean, it's approved for CLL, but not prior to venetoclax currently. And then, I think when you look at the data, I think the MIAC was super interesting. And again, you can't draw too many conclusions from that, but it certainly supports that these are both good options and very effective in this population. So I think having another shared decision-making discussion here is really important. I do want to add one more thing, and that's we didn't cover this, but having BTK inhibitor intolerance, so not resistance or progression on drug, but just inability to tolerate it for a covalent BTK inhibitor is a reason to switch to a different covalent BTK inhibitor. So I think that certainly is something that could be done. So there's data with both acalabrutinib and zanubrutinib, prospective data looking at switching due to intolerance to usually ibrutinib in those cases, and that works. So there would still be the options for a non-covalent BTK inhibitor ven-based, but that would be a reason to switch, unlike progression. And then I do want to address some of the questions that were asked, but maybe I could ask Dr. Davids to comment if he has anything to add before I take a look at our questions.
No, not really. I think that's a great summary, and I think that is a really important point to highlight, that if you have a patient who's having tolerability issues on a covalent BTK inhibitor, my choice is usually to go to a different covalent BTK inhibitor rather than going to pirtobrutinib, because I try to save that when I'm having patients who are having progression. So I agree.
Yeah, I completely agree with you there. I mean, there is a little bit of a question of what the intolerance is. So if it's something like intracranial bleed or something, then probably that would do it for the class. But especially for things like, headaches with acalabrutinib, joint pain, some of those things, I am, especially with ibrutinib, switching to one with lower cardiovascular risk. If people have AFib, that's not like AFib, that's the worst thing that ever happened to them, but like manageable AFib. I also agree. I like to switch to continue using that covalent BTK mechanism. So we got some extremely good questions that I think it's worth discussing. One of them is a question about a BTK inhibitor ven plus an anti-CD20, so triplets versus doublets, which I think we're going to discuss a little bit at the end. So we'll table that for now. But one that I think is important that we didn't really cover very much when we were discussing it, which is we repeated those biologic risk testing or biomarker testing before picking a subsequent therapy. And so we got a question about how often to do that. So as Dr. David said, some things like IGHV mutational status don't change. So you wouldn't repeat that, but people do acquire new abnormalities, particularly deletion 17p and TP53 mutations. So it's around 6 to 7% at diagnosis and upwards of 20% or more in previously treated populations. So it's very important to repeat that. And it's the same disease, it's just the cells, as they're exposed to therapies, acquire these changes that they didn't have initially. And then there can also be a change in the disease manifestations with more lymphadenopathy and less blood disease. So you can actually, or more cytopenias. So you can actually see variable disease manifestations from the same cancer as time goes on. And I think people usually with highly refractory CLL can actually have less blood disease than we tend to see earlier in the disease course, but everyone is an individual. And then kind of the last thing I think that it would be helpful to address right here that we haven't really talked about is we've mentioned a couple times combinations of venetoclax BTK inhibitors fixed duration, which we'll have some data on later. But the question is, if you do that initially, could you use those drugs later, or are patients resistant? Again, not a huge amount of data in that area, but the answer is yes. It does appear that people don't get resistance and that you can reuse those classes of drugs. Would the duration of response be as long as if you use them initially? We don't know. And Matt or Beth will jump in if they've seen any data on that. I have not, but it doesn't seem to make it so that you can't retreat. And I think some of the rest of these questions we'll table because we're about to discuss some of those in a few minutes. So now I was hoping that we could have Dr. Davids present our next case.
All right, yeah, so this is a new patient. This is my patient who's a 64-year-old gentleman who's an accountant, and he was diagnosed with early stage asymptomatic IGHV unmutated deletion 11q TP53 wild type CLL. So was doing well initially, went on observation for about 3 years, but gradually, especially over this past year, he's developed gradual progression of lymphadenopathy and fatigue, really some pretty significant lymphadenopathy, even on exam, 4 to 5 centimeter little baseballs there in the axilla bilaterally, starting to develop some cytopenias as well, with the hemoglobin now dipping below 10, platelets in the 1 teens. So has a bone marrow biopsy done that does show about 80% effacement by CLL. has repeat molecular testing, not the IGHV status because that doesn't change, but has repeat FISH and somatic mutation testing, still has 11q and TP53 wild type from the mutational analysis. This patient also has some hypertension like our other patient, also on one antihypertensive. This patient also has some mild chronic kidney disease. The creatinine clearance is just a little bit under 50. And of course, it's just always the worst timing with CLL treatment. It's now March, and this patient really does need to get started on treatment, but he's worried about time away from work because now it's the peak of tax season, and he's totally swamped. So he wants to know if there's a less intensive therapy in terms of timing that might be helpful for him. So I'm going to turn it over to the polling question. So what treatment options would you discuss with this patient? Would you do continuous BTK inhibitor-based therapy with or without obinutuzumab? Would you do ven-obin? You could do BTK plus ven plus or minus obin, or you could do chemoimmunotherapy with bendamustine and rituximab. So please go ahead and vote. So pretty evenly divided. So I'm happy to see not much chemoimmunotherapy, but between the others, it's roughly even with maybe a slight plurality here for BTK plus ven plus or minus obinutuzumab. But a lot of people also saying ven-obin, and then 29% saying continuous BTK inhibitor plus or minus obin. So Dr. Rogers, I'll pull you in here. What did you say and why?
Oh, this is so interesting because I think other than the chemoimmunotherapy, these are all very reasonable options. So this is someone who is going to get a first treatment that doesn't have those high-risk features. So I like the way that the most frequent response is actually the one that's not actually approved in the United States currently. But I think the data supports that that is effective. Ven-obin is effective. And then I'm going to talk in a minute about the addition of obinutuzumab to continuous BTK inhibitors. So I actually like all three of these, although during tax season, certainly the BTK inhibitor treatment is easier than the others.
Yeah, I guess one thing as you might discuss is if you do the BTK plus ven approach, it usually starts with 2 to 3 months of BTK alone. So maybe that would be enough to kind of get them through tax season and then go through the ven. So.
Yeah, I wasn't favoring that just because it's not currently on label, but that's an excellent point. I think unlike the obin ven where it's like obin and then ven, so it's 8 weeks of a lot of visits. That's true. You could start with the easier and then add the ven. That is a very good point for tax season for this person. All right. Well, is it okay if I launch into some of the discussion here?
Let's see the data supporting that.
Yeah, so I'll try to make this a little brief because we've already seen these studies earlier. So this is data from a study that was comparing BR versus ibrutinib and ibrutinib rituximab. But remember, the rituximab didn't really change anything here. So you've actually got these combined arms. They combine them for this, and it's showing you that. So it's kind of data from supporting earlier that with TP53 disruption, there's no difference in how ibrutinib continuous does, although that's less relevant here because we have someone without that feature. We've previously shown you the slide where adding rituximab doesn't make a difference. So for anyone choosing ibrutinib, rituximab as an anti-CD20 doesn't improve the progression-free survival, although it is an approved option. I certainly wouldn't do that. And now actually favor ibrutinib less just because of the increased cardiovascular risk. So I think that the option here really that we would discuss is from this study, the Elevate-TN, which again, we mentioned earlier, this is the study design, which is showing you acalabrutinib with obinutuzumab, acalabrutinib, and obinutuzumab chlorambucil. So this is showing a clear progression-free survival advantage to adding obinutuzumab. So for myself, for patients choosing acalabrutinib, I think it is very worth having a discussion about adding obinutuzumab for the first 6 months because you do actually realize this durable progression-free survival benefit. This is very different than rituximab added to ibrutinib, and I think actually we're now seeing with an update at 6 years that it looks like there's a survival benefit too, probably due to better disease control. So while the adding of obinutuzumab certainly wouldn't help tax season, unless you want to do taxes for people from the infusion room, it would improve the overall disease outcome. So it might not meet the personal goal of trying to get through tax season without doing as much intensive treatment. I do think for this patient, adding obinutuzumab to acalabrutinib would be an option. I'm showing you here a breakdown of patients with deletion 17p. And the reason I'm showing you this is that, as Dr. David said earlier, you do not see this benefit in the deletion 17p CLL patients. So our initial patient who did have deletion 17p CLL did get obinutuzumab added to the acalabrutinib, but that's not something I would recommend for someone with deletion 17p CLL because you don't really see a PFS benefit. It's certainly approved, so if you're someone that also has ITP or autoimmune hemolytic anemia or second reason to give the obinutuzumab, it would be fine, but I wouldn't do it to improve the response. So in our highest risk patients, you're not actually seeing a benefit. And then this is just showing you that the addition of obinutuzumab to acalabrutinib improves the rate of undetectable residual disease. So you do actually get better disease control. And I'll just leave it at that in the interest of time, since we already covered most of it. And I think people are more excited to hear what Dr. Feynman's going to talk about, which is these combinations that everyone was highly enthusiastic about for our last patient.
Yeah, absolutely. So thank you for that. The fixed duration Captivate study, I think we talked about this cohort earlier on. So what's interesting about this is that we heard at the very beginning about venetoclax fixed duration, and then now we have some data to support the use of the ibrutinib plus venetoclax for first-line treatment of CLL. In this study reported out last year, there were 136 patients without deletion 17p that were included in the study. And what's interesting is that the complete response rate of 56% met the primary endpoint. And what we also saw in this study is the progression-free survival with the fixed duration, as assessed by the independent investigators, was pretty safe. You know, they had most of the patients completed the planned treatment. The treatment duration was about 13.8 months, and the patients without deletion 17p did extremely well for a longer term survival. So this represents an opportunity for patients to have perhaps potentially a fixed duration on their treatment. And so then that will level the playing field, right? When we look at our patient with our golfer and our tax accountant as well. The next study is the UK FLAIR study, which we're really interested in, and this was just reported out in the New England Journal of Medicine actually a few days ago. This study looks at whether or not ibrutinib venetoclax and personalization of the treatment duration according to the minimal residual disease is more effective than FCR. We already heard that FCR isn't like the best fit for many of the patients. It's something that was historically used very often. But what this study looked at was assessing the minimal residual disease at various endpoints, again with the ibrutinib venetoclax versus that FCR. To the left, you can see the median progression-free survival in those big separation of curves. The gold line, the IV, was far superior to the FCR. And in terms of the overall survival, there did still seem to be an advantage. So what we're thinking about is potentially this represents another opportunity for patients to have not ongoing treatment, but shorter term treatment. And then this is a younger population. We heard also mentioned about the CLL13 study, which was first line venetoclax combinations in CLL. In this treatment-naive fit patients with CLL, no TP53. Again, we wouldn't want to give that ethically to patients immunotherapy if they did. And we heard from Dr. Rogers, again, it's, you know, upfront, it's a lower percentage of patients. It's more of an acquired longer-term thing. You worry about that TP53 or 17p deletion. In this study, patients were randomized in a 1-to-1-to-1-to-1 fashion. You got the chemoimmunotherapy. It was FCR if you're less than 65 years of age. It was BR if you're greater than 65 years of age, versus 12 months of VEN-R, 12 months of OB-VEN, or 12 to 36 months of the GIV, which is the obinutuzumab venetoclax ibrutinib. So then this now reflects like 3-drug combination, right? So we heard a discussion before, and we'll circle back to that. I'd like to hear what Dr. Rogers and Dr. Davis has to say later on. But at any rate, we saw that the venetoclax combinations were far superior to chemoimmunotherapy. Look at the venetoclax rituximab, though, down farther down the line at 60 months, there seemed to be a fall off of that therapy. So bovens and abutinib, obinutuzumab, and venetoclax for previously untreated CLL. Again, I had mentioned before excitement surrounding MRD negative status, and we can measure this in peripheral blood in CLL. And this study particularly looked at MRD negativity in peripheral blood, and then requested within 14 days a bone marrow assessment, which nobody loves bone marrow biopsies, but it does provide some important information for our patients. In this study, previously untreated CLL patients who met criteria for diagnosis had adequate ANC and platelet counts unless due to CLL, excluded if they had Coumadin and dual antiplatelet therapy, were started on Xano and Obi, and then after a few cycles had the venetoclax ramp up initiated. What we saw in this study, the progression-free survival in 50 patients to the left was not yet reached, and the MRD-free survival in the bone marrow and the undetectable MRD was also pretty impressive, 29.8 months. And so again, representing another opportunity for patients to have deeper responses with more than one drugs. Again, this is now 3 drugs. We had a comment in the chat before, and I'd like to again hear your thoughts. This phase 2 trial, again, not the strongest level of information. It's super exciting. Acala, obinutuzumab in treatment-naive high-risk CLL patients. In the study, 83% of patients with TP53 aberrant CLL had achieved this marrow undetectable MRD after 15 months. So again, the 3 drugs might be a reasonable option, and we might want to recommend this in patients, especially with the high-risk disease who confers a poor prognosis. In this study, there were durable responses with 93% PFS and low rates of cardiotoxicity with the Acala. Remember, the Acala is a little bit safer than the ibrutinib. That is historically what many of us had been used to treating before. So Acala Obi or AVO always reminds me of avocado. I love avocado toast. That's all the rage these days, and something that might spark some discussion, I think, after Dr. Rogers shared the summary slide. I just want to say we covered so much important information today, and so I can't wait to the further discussion that'll come after this.
Thanks. I think that was a very nice overview of combinations that are currently in development, and it'll be really exciting to see how some of those play out, especially as we get combinations with the newer BTK inhibitors. Someone asked us if in patients without cardiovascular disease, if the covalent BTK inhibitors are interchangeable. And I don't really think that's the case. So they all have their own specific side effects, like acalabrutinib is more likely to cause headaches. You see more neutropenia with zanubrutinib, and you still see a greater risk for atrial fibrillation and hypertension with ibrutinib. So even if someone doesn't have those, I don't know why you would want to put them at higher risk for that. So I think it'll be exciting because, again, ibrutinib is, we have more experience with it overall. So some of these combinations with it, with venetoclax, started before the availability of other agents. And I look forward to seeing how that plays out with especially the acalabrutinib and zanubrutinib. And there's actually some ongoing pirtobrutinib. Again, that's a different kind of class with non-covalent. But pirtobrutinib and venetoclax combinations. So that's going to be neat to see in the future. I don't know. I just want to say, did anyone else have some final comments before I go through some summaries and we have some more discussion? I don't know if no. Okay. So just to summarize some of the stuff we were talking about, hopefully everyone left here today understanding that there's a variety of highly effective options for the initial treatment of CLL. So while it's important to consider, deletion 17p or TP53 status, and I definitely said that that was the most effective, it is very reasonable to do what Dr. David suggested and do Ven-Obin for a variety of other reasons. And with so many good options, definitely a place for shared decision-making. I guess another take-home point would be that adding obinutuzumab to acalabrutinib improves the progression-free survival in categories of patients aside from those with deletion 17p. So I think that's something that should be offered to most patients, especially because there's a very real benefit there if people are open to coming for an infusion and suitable for obinutuzumab. I think venetoclax and obinutuzumab is highly effective, and the key there is that it's a fixed duration regimen. So proceeding with venetoclax and obinutuzumab can certainly reduce the physical and financial toxicity for patients. And then, these fixed duration BTK inhibitor Ven combinations have a lot of data So I look forward to seeing when those will be approved. We did get a question, and I look forward to seeing if anyone else has any other responses on this about how important it is to use approved therapies in your practice. I think in the US, when things are in the NCCN guidelines, we do have some flexibility regarding what insurance payers will reimburse for it, but I do try to stick with approved regimens unless I know something else is clearly better for the individual patient. We were talking about the exception of using Oben with Ven in previously treated CLL, but for myself, I do try to stick to label indications outside of clinical trials. I don't know if Beth or Matt has other thoughts on that.
I'll just speak because I see Dr. Davids was still muted. I think the weight of the evidence, I mean, you want to give what's right for the patient, the right medication at the right time for the right patient. And the evidence that's in the NCCN guidelines helps to underscore. I mean, this is a group of experts that are sitting together in a room that are deciding on the preponderance of evidence. And there's different grades of the evidence, right? And the NCCN guidelines were up to version 1.2024. So that's how fast the science is moving. But using the approved indication will help for the reimbursement. It helps to make you feel more comfortable in your decision making, especially if you don't see a lot of patients with CLL. And definitely, we talked about clinical trials, but we didn't talk about the importance about finding a great clinical trial for your patient. Ohio State, Dana-Farber, Cleveland Clinic, we all have great clinical trials. So try to encourage your patients so that we continue to move the science forward. That's all I have to say on that topic.
Yeah, that's a good point because we've had here at Ohio State for a long time, like BTK inhibitor venetoclax combinations studies. We had pirtobrutinib back when it was called LOXO 305 and it was in initial testing. So participation in a clinical trial is a way to allow your patients to benefit from tomorrow's treatment today. So that is definitely something that we didn't cover a lot of, but is very important. I don't know, Dr. Davis, did you have anything else to add?
No, I mean, I fully agree with all of that. And I would just emphasize, I think there is a little bit of a perception now that CLL is solved and our patients are all doing just fine. And unfortunately, that is not the case. And I think especially for our younger patients, we really don't know what the long-term results are going to look like with the two major targeted therapy classes that we currently have. So certainly clinical trials remain important. There's a number of immune-based approaches that we haven't had time to discuss today, things like CAR T cells, bispecific antibodies. So I think you should always consider clinical trial options for the right patients, and need to continue to enroll to these trials to move the field forward.
So I think that is an excellent, that kind of covers our final point that we need to continue to study optimal combinations and sequencing, but also new therapies. And then we'll just end by going over some take-home points that are kind of specific from today. So that's to incorporate molecular testing for all patients. And again, I've considered BTK continuous monotherapy, but I think Dr. Davids made his point about the alternative. For patients with this high-risk feature, adding obinutuzumab to acalabrutinib for patients who do not have deletion 17p CLL. And then we covered a lot with pirtobrutinib, considering it certainly based on the evidence after covalent BTK inhibitor resistance, and then for its current label indication, which is after covalent BTK inhibitor and venetoclax. I will point out that there is no data to use that before covalent BTK inhibitors currently, and I think no one here would recommend that right now. While it is a fourth BTK inhibitor, I like to think of it as a different class of drug, even though it hits the same target, similar to BTK degraders. And then obviously consider the value of clinical trials of these BTK inhibitor venetoclax combinations, but based on everyone's response to the last polling question, I think we've built some excitement for that. I think there's a lot of upcoming questions that everyone's asked about sequencing and also when to add an antibody, that there's just not enough evidence right now to completely answer those questions, but I look forward to seeing how that pans out in the future. With that, I think we're about at time. So I'll just remind everybody that to receive CME or CE credit for today's program, you must complete the post-test and evaluation online, and then participants will be able to download and print their certificate immediately upon completion. And then just leave you with the link here to the CEC Oncology Hub to access additional activities on relevant oncology topics, as well as some resources and actually patient education materials, which might be useful. So with that, I would like to thank Dr. Feynman and Dr. Davids for joining me today, and for all of you for attending this presentation. And hopefully everybody's left here with a greater understanding of the variety of really effective treatment options for chronic